Good evening. The outbreak of Ebola in Zaire is spreading fear and horror around the world. One major reason, most people don't survive the infection. Tonight we put the virus under a microscope. One of the first doctors to discover Ebola will tell us whether we should worry, and a medical author will explain how Ebola compares to other dangerous viruses. We begin our examination with a report on the history of a killer virus. Here's Primetime's Eve Savory.
From the vast forests of Africa, a threat once thought contained has re-emerged. One of the world's deadliest pathogens, Ebola.
I think any time that you have an agent that can kill somewhere between 50 and 80% or 90% of the people that it infects, and that there is no treatment other than supportive therapy, that's a pretty scary proposition.
Your town is being quarantined. We got 19 dead. You got 100 more infected. It's spreading like a brush fire. What are you talking about?
Until the movie Outbreak came out, Ebola was just an obscure and rare Central African disease. Outbreak is the story of an American town decimated by an Ebola-like virus after an infected monkey is released. It and several recent books are based on a real threat from new and emerging viruses. Dr. Kevin Kane of Toronto Hospital's Tropical Diseases Unit travels to little-known parts of the world. There he works with local people to identify and bring back samples of new and exotic diseases.
When they enter into people, they're often poorly adapted to the new host, which is us, and you often see a bad outcome, bad disease as a result of that new interaction.
Ebola's first recognized outbreak was in 1976 at the Ebola River in Zaire. This is the abandoned missionary hospital where villagers came for treatment. These are the hospital staff who died. There was a second outbreak in 1979, and then nothing for 16 years until now. A city of 600,000 is under quarantine, and both virus and panic are spreading outside the city. This is the Ebola virus, magnified 17,000 times. It's a long, stringy, filament-like virus, what they call a Class 4 pathogen. That's as high as it goes, and it requires handling in a Class 4 facility like this one in Atlanta at the U.S. Centers for Disease Control. That's because there's no treatment, no vaccine, a high fatality rate, and it is spread person to person. Although the disease starts like the flu, the later symptoms spread the virus.
They'll develop bleeding manifestations, and they can bleed and leak from any mucous membrane, their eyes, their bowel, their bladder, as well as having massive necrosis or death to the liver and renal failure.
Rural hospital conditions in Central Africa are primitive. Patients must bring their own syringes or share. Infection control is minimal and often non-existent. It's hard to contain a virus from a heavily bleeding, perhaps convulsive patient under these conditions. But it doesn't necessarily follow that the disease is spreading through the air. Dr. Jay Keystone heads the Tropical Diseases Unit.
It is clear from looking at the epidemiology of these outbreaks that aerosol transmission up till now has not played a major role. That it really is through contact with secretions and excretions and blood of infected individuals, and that's close face-to-face contact.
As humans move ever deeper into areas never even explored, we are changing the balance of ecosystems, encountering pathogens we've never seen before.
This occurs not just in the tropics. I mean, we just have to look at the western United States with the outbreak of hantavirus, the eastern United States with the increase in Lyme disease, as man has interfered in the ecology.
Where Ebola lives when it's not causing epidemics is a mystery. Many researchers believe it resides harmlessly in a primate. But wherever Ebola lives, others may too, and they may be less easy to contain.
I guess what I'm worried about is the son of Ebola, the other agents out there that are relatively untouched now, but as we continue to forage into new ecosystems, may have an opportunity to get into human populations. And because of the very small global planet we live in, the potential for those to be rapidly disseminated.
Researchers say the threat to Canada from Ebola is remote, but not non-existent, not in the age of jet travel. A person can leave Zaire with no symptoms and show up at a Canadian hospital a day later with vague complaints of feeling ill.
Our concern is that someone goes to a doctor, comes to a hospital with some of these symptoms, doesn't indicate that A, they've been recently in Zaire, or the person doesn't ask the appropriate questions in terms of travel and has maybe coughing, maybe bleeding, in other words, may have set up the situation where person-to-person transmission could occur, but the index of suspicion is not there.
What most troubles them is that Canada's contingency plans are still only in the early stage. Although the Ontario government had built a level 4 laboratory, it's on hold because people nearby didn't want it in their neighborhood. In the event of an outbreak, Canadian blood samples have to go south.
Someone has to get on an aircraft, hand carry them down to a lab in the United States, and we're not guaranteed that that laboratory is going to respond to our needs if that laboratory happens to be caught up with problems of their own. For example, CDC has been very good to us up till now, but what if they have a number of cases? Their priority is for the United States. Their priority is not for Canada.
Canadians have been lucky so far. Most of the infectious agents we encounter are familiar ones, easily diagnosed and usually treatable. But infectious disease specialists warn we shouldn't be complacent. There may be other agents, even more virulent than Ebola, lurking in the forests. For Primetime Magazine, I'm Eve Savory.